those real sticky stickies.
Yeah.
All right, ladies and gentlemen.
There you go.
Take your seats, please. We were going to live stream it today for the very first time, but unfortunately the Wi-Fi is not cooperating. So we're going to record it instead. That doesn't really apply to any of you other than the fact that if you want to go back in and watch this program, you can do so later, and it will be there for your attention. So, welcome to APDA's Take Control series. My name is Jen Gillick, and I am the program director at the American Parkinson Disease Association. We know that Parkinson's is a complex disorder, and it affects everybody a little bit differently. It's this snowflake disease. And we really feel that the more you know, the more educated you are, that the more empowered you can be in living with Parkinson's disease. So we've designed this series of programs to bring in experts in the field to talk about different topics. So we will have 5 programs right here in this room, and live streamed, maybe, and recorded, for sure, to bring in experts to talk about different subjects. So it'll be the second Friday of every other month at 10:30, same time, same place, right here on the second Friday of every other month. And information about that is up on our website. I will tell you a little bit more about what we do in our programs and services right before I introduce our second speaker. But before I introduce our first speaker, I want to go through a couple of housekeeping things. The restrooms are located to my left over here. There is water and snacks. Please help yourself. After the first speaker, we will be having a little break to stretch your legs, get a little snack, and then I'll call you back together and we will have the second speaker. These PowerPoint presentations that the speakers have, I will be uploading those to our website, so you don't need to take, you can take notes, but you don't have to take mad notes. They will be available for you to reference afterwards. I think that's it for now. So I'm going to introduce our first speaker. Dr. Reza Ghomi is a neuropsychiatrist at Evergreen Medical Center. And he is here to talk about cognition in Parkinson's disease and what you can do about it. And I met Reza like a year ago, and I was like, you're going to be my new best friend because you have so much information in that head. So I'm really pleased that he can be here with us today. So come on up to the stage or the carpet here, Reza. Thank you for being here.
Yeah, you're very welcome.
And here's your stage right here.
Hi, everyone. And I think these slides will be shared with you, so if I jump over something or move a little quickly, don't worry. Okay, you'll have a chance to study it in detail afterwards. My goal for today is to focus more on the neurocognitive effects of Parkinson's and where it fits into the broader umbrella of dementia and early signs, what to look out for, how you get tested, treatment, prevention, and resources to help you navigate when you do go to clinic or when you do interact with a provider. I do also, my research is more focused on voice technology. Some of you may have come across it. I recognize some faces. I worked at the VA before and UW, and then now I've started a memory clinic at Evergreen on the east side. So still collaborate on research, and my research is heavily involved with voice detection, but it's nothing to do really with today's talk. So again, I want to just touch on, give you some education regarding, because I find it honestly, it's relatively confusing, navigating, Parkinson's disease, then Parkinson's disease dementia, then you probably hear Lewy body dementia a lot, you hear mild cognitive impairment. So I want to just sort that out for you a little bit. And I think education goes a long way here because you will often find 2 providers that might give you a little bit of different information. So it's not an easy thing to find clarity about. So Parkinson's disease, just as a reminder, right, it's extremely common relative to, when we talk about diseases. We're at about 1 million people in the US, and the number's growing rapidly, whether that's, is it new cases, are we getting better at detecting it? That's being investigated, but the point is it's quite common. Washington State has quite a few. It's on the higher end of nationally in terms of how many people per capita. And that's just probably because we have some, major cities, we have good care, here. There's lots of reasons for that. And of course, I know if you or your loved one has Parkinson's, you're used to hearing about the motor symptoms, right? And they focus on the levodopa, getting your dopamine tweaked. You got, various treatment options with that. Sometimes that helps, actually, the initial cognitive symptoms. And so sometimes that kind of masks it, it hides it, right? Where you might get that little perk up, you feel better, and even though cognitive symptoms are sort of there, maybe they're not as noticeable. Your obviously response to levodopa really helps make the clinical diagnosis. We don't really do a lot of fancy tests anymore. Some of you may have had a DAT scan, but that's really more when there's something confusing happening. But really, it's a clinical diagnosis. What do you look like in clinic? And if it's really obvious, primary care, anyone can really diagnose it, but often you come to a movement disorder specialist when it's a little bit more confusing or if there's other things involved. And so today, I'm really thinking about more the non-motor symptoms, okay? I think it's easier to understand the motor symptoms because they're visible, you can really see them. But the non-motor symptoms, especially later in the disease, really tend to be the biggest impact, both on the patient and the caregiver. So that's where I come in, my memory clinic at Evergreen, but really what we were doing with the Memory Center at UW, with the Movement Clinic, we spend a lot of time focusing on non-movement symptoms. So I want to give you just a general overview because even the term dementia I found confusing when I started training. And dementia, all that dementia means is there's a chronic and persistent cognitive issue going on. There's a slow progressive decline and you're at a point where you're needing help with some of your activities of daily living. So whether that's you can't do your taxes anymore, or you need somebody to help you remember to pay the bills or remember your appointments. As soon as you cross over having trouble in your daily life, forgetting something, spending hours looking for your glasses, there's a lot of gray zone there. But once you get to that point, that's when it's called dementia. But that's all that means. It has nothing to do with what's going on inside your brain. All that means is what do you look like to even just your friend or your loved one. Okay, so anyone can diagnose dementia. You don't have to be a clinician. It has to do with your functional status, okay? And so dementia, I want to point out, is not part of normal aging. I'm sure many of you remember maybe great-grandparents or grandparents, many, many years ago, and it was I find a lot of people think it's normal. Oh, Grammy, everyone gets demented, when after 80. That's really not how it's supposed to be. And so we want to try to change that view a little bit. So some key points for today. So most dementias that we see in clinic, especially nowadays, we've gotten pretty good at treating a lot of the preventable or treatable, cognitive issues. So they're going to be slow, progressive changes. Alzheimer's is the most common, and whether or not you have Parkinson's doesn't change your risk factor for having Alzheimer's. That can still happen. But Parkinson's disease, being the second most common neurodegenerative disorder, can also cause dementia. And then, of course, a little bit further down the line is Lewy body dementia. We'll get into what the difference is there. So touching on some of these common sort of misconceptions we're always trying to champion changing here, right? It's okay to talk about it. We want to have an open environment. We want to expand resources for everybody, caregivers, patients, family, everyone. And we want to make this a much more comfortable environment for everyone involved. And actually, Nate talking afterwards will be going through a lot of the rehab and type of exercises and really things you can take control of in your life. So just to point out a couple things before we launch into sort of what's not normal, keep in mind, and on the left-hand side, it looks like it's changing a lot, but it's it's zoomed in. It's it's from 35th kind of percentile, think of it to 60th percentile. There are going to be some changes as you get older. If you keep in mind, things like verbal ability and calculation, number ability, really shouldn't change. So when people say, oh man, my great-grandfather was like 98 and he could still do all the math very well, that's how it should be. But keep in mind, speed, the speed of things, processing speed, perceptual speed, spatial orientation, those things can sort of trend downward as we get older, and that's the kind of thing where people will notice and say, oh, I'm just getting older, things are slowing down. That's true. But your ability to do the things should still be there, okay? And this is how we think of neurodegenerative disease, how we think of cognitive changes when I think about Parkinson's and how it's progressing. As you live, the longer you live, and this could be as young as 20, 30 years old, right? There's young onset. There's slowly this neuropathology building in the brain. That's the gold line. And at some point, you'll start to notice some differences, and it might be subtle at first. It might only show up on testing, and it may not be interfering with your life at first. But at some point, that line will cross with your function. The red line is your function. And when those two lines cross, that's what we call dementia. So why I'm here is partially because I think it's extremely important to know what specifically is going on in everyone's brains, and that's how we advance treatment. That's how we advance research. So if I were to ask 20 years ago, if I had a new idea for a cure for Parkinson's disease, dementia, let's say, and I enrolled 100 patients back then, at the end of the study, I may very well have ended up with 50 patients that didn't actually have Parkinson's disease dementia because we weren't that good at figuring out, is it Lewy body dementia? Or actually it was Alzheimer's, but they also had Parkinson's. There's a lot of complications there. So the better we get about talking about it and then labeling it, the better we can on the science side figure out, well, this is a treatment for, for this specific thing. Because we're finding out now dementia is a very broad term. Many things fit under that umbrella. So that's one of my kind of biggest cheerleading sort of stances. A couple other things I'll point out. When you go to clinic, it'll probably come up at some point. Keep in mind, many people with Parkinson's disease will live a very long life and have very minimal cognitive changes, but it will affect also many of you. When you go to the doctor, I think it's important to sort of be organized because some people walk away with the diagnosis of dementia. Some people say specifically Parkinson's disease dementia. Some people will say, something else. I think it's important to think of it as dementia. Here, actually I have the pointer, I forgot. Dementia, mild cognitive impairment, are severity-based measures. Just like, so any of us can kind of give us each other these labels. This is just based on how you're doing. So this is in one important aspect. But when you come to the doctor, they will start putting together the syndrome-based label. And so you can see Parkinson's disease dementia is a syndrome base. It still doesn't actually indicate the neuropathology, meaning if I were to look at your brain under a microscope, what do I see? Parkinson's disease dementia doesn't get specific enough. But keep in mind here, Alzheimer's disease, when we say it, interestingly enough, we actually mean technically that there's tau and amyloid proteins in certain parts of the brain. But I'm sure you guys are used to hearing, well, I know tons of people that are diagnosed with Alzheimer's disease and they didn't have a brain biopsy or, there's no way to look at it. That's true. So we're guessing. What we really should be saying is probable Alzheimer's disease. So really, for anybody that's living, unless you got a sample of your brain taken out, or some of the newer, fancier tests, we have these amyloid PET scans that are in the process of being approved by Medicare, so those will be out soon, safe ways of testing. That target that amyloid, we really got to be careful about what we're saying. So, and this is all just to help you understand that it's confusing because terms will be thrown around, and you'll hear one person say probable, another person says it is. This is why. There's a little bit of, uncertainty. And so Parkinson's disease dementia is a syndrome. It's a constellation of symptoms, right? Dementia with Lewy bodies is a syndrome. I can only confirm Lewy body disease once I look at your brain directly. So Lewy body disease causes dementia with Lewy bodies and Parkinson's disease dementia. So I'm talking about the specific proteins at that point, okay? So again, I don't want to be confusing. I want you to understand that you might hear severity-based terms thrown at you, you may hear these syndrome-based, and then you may hear neuropathology-based terms, okay? I'm suddenly regretting putting this up here. This may be too confusing. So we're going to go ahead and skip this. I don't want to be confusing, but it was just reinforcing severity, syndrome-based, and neuropathology. So clinical diagnosis. I spend a lot of time, if you come to clinic with me alone, I'm not going to be happy with you. I always ask, the schedulers, please make sure whoever's coming in brings someone, because I need to know someone that knows you well what they think. Because once your memory starts slipping, you can't be trusted, okay? It's hard for me to know what's going on. And plus, we're all like, even me, if you ask my wife what I did, she's going to give you a different answer. So it's important to know what other people are seeing. So I spend a lot of time going through that history. I go through a pretty comprehensive list of preventable or reversible causes of cognitive decline. As we're getting older, it's pretty common that our thyroids sort of stop working, and that comes up every so often. Of course, primary care is really good at catching a lot of these things, so by the time you're seeing me, it's relatively unusual that I'll catch one of these things, but B12 deficiency, for example, can cause reversible cognitive decline. So we'll kind of go through the list, and once I know, okay, everything else is kind of tucked away, there's something going on in the brain beyond that, that's when I'll start thinking about how do I want to confirm what's going on. And if you have confirmed Parkinson's disease, that's a big clue. But where I keep going is I want to know, well, is there Alzheimer's disease also? Was the diagnosis of Parkinson's disease accurate? And what I mean is not that your diagnosis is wrong, but is there more of a Lewy body dementia going on? And we're going to get into the differences there. So I do a lot of teasing apart of that kind of thing. And this takes time, which is why there are people like me that really focus on it. And again, and point is continued follow-up, meaning don't worry if the answer is not clear after a first appointment. Sometimes it takes a few months. See how things play out. One test I recommend, and you may be going to doctors, and it's sort of this. When you look back historically, right, there have been cognitive tests that changed over the years. Right now, the one that's sort of in vogue is the MoCA, which came out of Montreal, which is why it's called the Montreal Cognitive Assessment. It's a pretty solid screener. I will say, a lot of these tests, because they're meant to be done in just a few minutes, if you are a high-functioning, college-educated, very smart person, you're going to probably have to get to a pretty far along that spectrum I showed you before the score will start going down. So we don't consider it very sensitive, but it is among the quick tests, I think, the most sensitive. And so you might have a doctor that did an MMSE, a mini mental status, where they have you remember 3 words or write a clock. There's a few other versions. I'm a fan of just using this form because it's standardized. It's been done millions of times, so we know pretty well where your score should be, and even for different stages of cognitive decline. So just keep in mind, don't worry about all the, if you haven't had a MoCA done, it's probably a good idea if this is a question in your mind. And primary care, anyone can do it. So the first stage of memory decline, once it comes on the radar clinically, meaning your MoCA score is starting to get lower, or if that's not sensitive enough, maybe I need to send you to the neuropsychologist, one of our colleagues, and they'll sit down for several hours and test you very thoroughly. And they will find out, okay, when you were, let's say, at your peak, 30s, 40s, 50s, this is where you were. And then they'll find out exactly in different domains, meaning your spatial function, your visual processing, verbal reasoning, logical recall. I mean, it's like a really long SAT. Okay, so it's people don't like it when I send them, but some people that they think it's fun, but it is a long day. But we will get a really clear answer. And if your test scores are slipping below where they should be, but you're still functioning fine, you're driving, you could still even be working, that's what we call mild cognitive impairment. So the point is no functional impairment. you're doing okay, but you feel like something's good, something's changing or someone else does, and I can measure it somehow. If I can't measure it, then I'm not going to even call it mild cognitive impairment, okay? So, and then there's sort of different subtypes. So cognition in Parkinson's disease, let me just make sure I didn't miss it. Yeah. So in Parkinson's disease, mild cognitive impairment we're finding, and in fact, APDA sort of handout they have on Parkinson's disease points this out. It's more common than we thought, and it starts earlier in the disease likely than we thought. But remember, once you're diagnosed with Parkinson's disease or the lens is really focused on your movement symptoms, your motor symptoms, it's easy to miss, right? Because we're so focused on making sure your stiffness is getting better, your bradykinesia is getting better. So it's a point of improvement, but it's not don't think of it as it's an error. It's just that we're getting better at detecting it. Common issues, impairment of attention. This is why I think sometimes levodopa will help. Dopamine, it sort of acts as a stimulant, right? When you give kids that have attention deficit, Adderall and Ritalin, what are they doing? They're boosting their dopamine levels. So if I give you some dopamine, yeah, it's going to help you move better. It's also going to help you pay attention better, and it'll probably mask that cognitive decline a little bit. Working memory, executive function, visuospatial function. These are all fancy ways of testing different parts of your brain that we've come to separate out. So MCI in any setting, not just Parkinson's disease, can progress to dementia, meaning those Lewy bodies decide, okay, you know what, we're not going to stick around this basal ganglia, this core part of your brain. We're going to start going out to the cortex, and they start depositing, and that can lead to dementia as that builds up. So PD patients have a 4 to 6 time increased risk of dementia compared with your age-matched controls, meaning your normal, disease-free, I should say, partners, right? So it is just much more likely because there is Lewy bodies up there, and it's very easy for them to start moving outside that movement part of the brain. And again, so I do a lot of cognitive testing to try to tease that out. So real quick overview, again, dementia, core clinical criteria. You have to have cognitive behavioral symptoms that interfere with your ability to function at work or your usual activities, okay? This is why we really harp on knowing what your partner or caregiver, someone comes with you, is saying. If they're saying, you know what, last year they were doing the taxes every year, and then last year they weren't able to do them. That's a hint, okay? And I need to know that. Not explained by delirium or major psychiatric disorder, meaning if you're extremely depressed, I can't really call it dementia. I got to make sure your depression's better. So keep in mind there are plenty of things that can cause what looks like dementia. So again, I kind of touching on all of these things before. Now, Parkinson's disease, I just want to spend a little bit of time in Lewy body dementia. I get this question a lot, very understandably. I still have to ask myself, and I'm constantly looking at the literature as it evolves. But how many people here have heard of dementia with Lewy bodies? And then how many people have heard of Parkinson's disease dementia? So, and then how many have been told that you have one or both of them? Has anyone here? Okay. So it can get confusing. You might hear both terms. Really keep in mind that even in just the last 10 years, it's a work in progress. So you're going to find some disagreement, but overall, it's really pointing to the fact that both diseases have to do with Lewy bodies, which are alpha-synuclein deposits, and they're depositing in your brain. The order at which they deposit and where they deposit tends to manifest as these sort of two different syndromes, okay? Dementia with Lewy bodies or Lewy body dementia. So the point is that it's dementia, meaning you have to meet those other criteria we talked about. But you have to have these deficits in cognition. It has to be affecting your life. But these are the key features. And this can be there with Parkinson's, so keep in mind. But it's about when it happened in the course of things. So fluctuating cognition, meaning people will say, oh, my partner, they tend to be more confused, not know where they are, get a little more confused later in the day, or there's this fluctuation within the day. That's an important piece. Keep in mind, when we get older, if you're super tired, you did something exhausting, one-offs don't count. This is a pretty established pattern. Recurrent visual hallucinations, typically well-formed. People tend to see well-formed animals. They'll see loved ones that maybe are deceased, like their parents or aunts and uncles, things like that. But pretty well-formed, meaning they'll know. They'll say, oh yeah, John was here. Spontaneous features of Parkinsonism. So again, because it's Lewy bodies, you will typically see some tremor, some rigidity, a little bit of what we call Parkinsonism, so things that look like Parkinson's disease. And then Rem sleep behavior. This one's a tough one. Be careful if your partner's going to come out very quickly in the appointment and say, oh yeah, I can't sleep. You know, he likes to yell in his sleep. That doesn't count. Okay, but it can kind of be misleading. We really need to know that the person's acting out their dreams. You know, that you come in, the bed's all thrashed up, sometimes they fall and hit their head on the nightstand. It's movement in dream stage sleep. So talking in your sleep is actually normal. So if someone's just kind of sitting there talking, even yelling occasionally, that's totally normal. It's a loss of tone below the neck, think of it that way. So your inability to be frozen while you're sleeping. When you start acting out, that's REM sleep. Sleepwalking is not REM sleep behavior. That's non-REM sleep behavior. So again, if someone's kind of quietly going to the kitchen getting food, it doesn't count. Okay? So if you take Ambien, that might happen, and that's not pathologic, don't worry. But REM sleep behavior, and you might have seen some, I saw some headlines this past year, we're finding people that have REM sleep behavior later in life, over 80%, it's correlated with Parkinson's disease. So they're very related with Lewy body pathology. So differentiating Parkinson's and Lewy body just a little bit, just kind of trying to hammer this down, honestly. Lewy body, it's nice if there's minimal or no resting tremor. That helps me understand that, okay, I'm a little less concerned about where the Lewy bodies are right now. Less likely Parkinson, more like Lewy body dementia. Early dementia within a year of motor symptoms. That's really the sticker. You got to have memory decline and dementia type symptoms pretty quickly, either before or right after movement symptoms. So you might get Parkinson's disease diagnosis, and then 8-9 months later, if we see all these other symptoms clearly, that's probably going to revise your diagnosis a little bit. You're still going to have Parkinsonism. That's still there. But again, we're just trying to be sticklers about where are the Lewy bodies in your brain. Hallucinations, sometimes delusions or impulsivity, which I'll touch on a little bit later. Again, and this is the hard tug of war, right, that many of us are familiar with. I give you dopamine, it makes your movement better, but it makes visual hallucinations and psychosis, paranoia, those things worse. That's just a fact for all of us. That's why when you go on the street and you see anybody doing meth, they're flooding their brain with dopamine, and guess what? They look completely crazy, right? Because they're paranoid, they're delusional. That's what dopamine does. So there's just no way around that. That's why there's a lot of fancier new formulations and drugs trying to avoid it going into your brain and keeping it in your body. So there are some methods to try to keep it out of your brain, but if it gets in your brain, it's really hard to avoid these sort of psychosis type symptoms. Limited or no response to Parkinson's medication. So often we see some of that Parkinson symptoms, then we think, okay, but there's also some dementia, so we try the levodopa, and you don't get that much better. That's also pushing us towards this sort of Lewy body dementia type diagnosis, because for whatever reason, it doesn't tend to be as affected by levodopa. I'm going to touch on just some treatments real quick. The point is, there's medication, there's non-medication, and I really want to focus on non-medication, but you're going to hear about these, and I think you should know about them a little bit, okay? So the acetylcholinesterase inhibitors, you might have remembered, there was all these commercials on TV for Aricept, Exelon, are kind of the familiar ones. These ended up being studied and approved for Alzheimer's, but it turns out, and think about it, when a drug company gets their approval and they can go to the market, there's not a whole lot of reason to spend a lot of extra money to study then people with Parkinson's, right? But guess what? It can help people with Parkinson's. So it's called off-label use, but we very frequently prescribe these for people with Parkinson's or Lewy body dementia once they start having those memory issues. And all this is doing is flooding your brain with a neurotransmitter and saying, hey, we can't cure the disease, but giving your brain some of that neurotransmitter to just try to do more with what it has, okay? That's all that's doing. So And believe it or not, with Lewy body dementia, it's interesting. It's actually the disease that tends to have the strongest reaction in terms of improvement with these medications. So even though they're approved for Alzheimer's, those with Lewy body dementia or Parkinson's dementia can have a pretty good response to these. And then this other class of medication called Nmda receptor antagonists is Memantine or Nmda. That also can be added later. That's meant to be for once things are in a more severe stage. But often we will do this with patients with Parkinson's disease. So I want to kind of just march through some of the other symptoms, right? So the non-motor symptoms we're talking about. So cognition, of course, is one of them. Right now, there's lots of new studies actually going on right now to help cognitive symptoms. Depression is a big non-motor symptom of Lewy body dementia and Parkinson's disease. Very high prevalence among Parkinson's disease, right? Really big concern for suicide. So I get worried when I have someone with Parkinson's who's depressed, having suicidal thoughts, and they're also on a whole bunch of medication involving dopamine. And what does dopamine do? It gives you lots of energy. And I want to be careful if I'm giving you lots of energy and you're thinking about hurting yourself, right? So keep in mind that when you're for yourselves and for your loved ones, it's something to keep an eye out for if depression's an issue. And there are treatments. And in fact, at the VA when I was there, we wrote a paper, my colleagues wrote a paper that even ECT, very effective. And in fact, it was interesting, people that did ECT, their depression got better, and many of them actually went off or lowered their Parkinson's medications quite a bit. It sort of stimulates the brain. And remember Robin Williams? Of course, while he was alive, we didn't know, but then after he died, do you guys remember what came out, what his diagnosis was? It was in that realm of Lewy body disease, but he had dementia with Lewy bodies. And so he ended up, everyone thought he had bipolar and this and that, and it turned out he had Lewy body dementia, and he ended up taking his own life because he fell into this category. And it wasn't really caught. And so this was actually preventable. And so his wife wrote a very helpful letter, and it was published in the Neurology Journal, the main neurology journal we have. It's public, you can look for it online. Very helpful letter that asked for more attention to this. So keep in mind, antidepressants, I'm just calling out a couple, there's tons, right? I'm calling out a specific few. Citalopram just has been studied really well in dementia populations, older adults with dementia. Tends, for whatever reason, in the studies, tends to be the most helpful. And that's Celexa is the brand name. Another symptom, anxiety, very common in Parkinson's disease, extremely common. Again, adding dopamine and those medications sometimes can increase anxiety, so we have to be careful about that. But also very common. Panic, social phobia, we really got to fight this trend that once you start having memory decline or even Parkinson's by itself, there's a tendency to isolate, not go out as much. Obviously, you guys don't fall into that category, so that's a good thing. So we want to really help those with Parkinson's, make sure they're staying social and overcoming these symptoms. Hallucinations is a big one. Keep in mind, the vast majority of people that have Parkinson's, many will have hallucinations, but the majority will not be bothered by them. Sometimes it's important if it's your partner or loved one that has Parkinson's to remember, oh, they're telling you they saw, let's say, a deceased loved one, something like that. That's okay. I'm really going to intervene only when they're running out of the house screaming, or having a lot of trouble with that visual hallucination, which is a minority of the time. It's really not common. That's when I might go to a medication or talk about how to change the environment. But just keep in mind, just because this is happening, no reason for panic. In fact, many people find it sort of calming. They'll kind of sit there, they might even talk to the loved one or have a conversation. There's really nothing wrong with that. Oftentimes it's scarier for the people around them. if it's happening all of a sudden and it wasn't before, and it's sort of, keep in mind it could be a sign of medical illness, meaning they could have a urinary tract infection, they could have a pneumonia, a subtle one, that can make you delirious. And hallucinations with delirium is something you need to get treated, right? It's a medical issue going on. But what I'm talking about is that once in a while, part of the disease, part of the dementia, it can be pretty well tolerated. When we do get involved, and many of you may have heard of these, we start to rely a lot on atypical antipsychotics. These are medications that were heavily developed for people with things like schizophrenia or bipolar disorder. But it turns out, because some of the symptoms are similar, we tend to try them for those diseases. So you may have already been on some of these. So quetiapine, clozapine are good go-tos. Their efficacy is not great. They're not super effective, but they're also least likely to mess with your Parkinson medications. They're not going to strongly fight the dopamine meds. So that's why we try those. Pimavanserin, you guys may have come across this a little bit. It's recently approved. I think I have a couple slides on it. Look at that really nice logo. Gorgeous. Look at that. They spent a lot of money on this name. It's recently approved. It's still relatively, it depends on your insurance. I mean, some insurance is better covering, but bottom line is it's very expensive. It attacks your visual hallucinations and your psychosis symptoms. It's approved for Parkinson's disease dementia. It's the only drug approved for that. And so it's doing it a different way, and so that can be helpful. So usually what we'll do is we'll try one of the other drugs, mainly because of cost, and then this will come into play when, if those aren't working, if it's really an issue. So I would say I still see this relatively uncommonly, and that's just common when a new drug comes out when it's very expensive, but just something to keep in mind. Yeah, it was approved in 2016, so it's been a slow up. It's also got a very specific approval, so it's slower to get taken up. I'll just skip over that, but I'm just putting in some data so you guys have it. Rem sleep behavior, again, really important, and can have been happening for 10, 20 years before you were diagnosed with Parkinson's disease. Keep in mind, some people say, oh yeah, I've been acting out my dreams since I was 30. And again, be careful. I worked at the VA, and there are a lot of vets with PTSD, nightmares, and again, you got to be really clear that the dreams are being acted out, not waking up or having a behavior as you're falling asleep or just as you're waking up. That there's a lot of subtle differences, but it's making it clear that it's happening while you're dreaming. These other sort of symptoms that happen earlier in life can be sort of a hint towards Parkinson's disease: loss of smell, constipation, depression. If you kind of get a cluster of those. Oh, sure.
All of these symptoms, smell, constipation, if it happens 10 years after the diagnosis, then what?
If it happens later, I would say it's a miracle, but I would be very surprised. But it may. I mean, it's not that it's impossible. It won't change anything. It'll still, that'll still be your diagnosis.
Can you repeat the question when people ask you a question?
Oh, sure.
Video?
Yeah, the question was, what if these other symptoms, smell, constipation, depression, happen years after your initial diagnosis of, and yeah, hopefully you're one of the lucky ones that it's later, but I don't know if I've come across that yet.
Yes.
And some people will live, yeah, and some people will go without it, and that's a good thing. Let's see. Yeah, so anyways, just jumping down here. Melatonin is surprisingly very helpful. Higher dose, you can even go up to 20, 25 milligrams. Sounds really like we're pushing it, but it really helps Rem sleep behavior, that sleep behavior during sleep in Parkinson's disease. So, and this is over the counter. You don't have to wait for your doctor to prescribe this, but keep in mind, over the counter they usually sell 3 or 5 or something. You can go up to 10, 20, and then you let your doctor know, of course, but it's not gonna interact with any of your medications, so it's safe to try it. That usually does the trick. And then if it's really a problem, they're jumping out of bed and they're like coming in with bruises and they're bleeding, which does happen, then we might use benzodiazepines. Okay, just low dose. I think this is the last non-motor symptom I was just going to touch on. Impulse control disorder. Just bringing some attention to something that's very common. Again, what are we giving you? We're giving you dopamine. This is another thing that dopamine can cause, right? Just like some of the street drugs. But in a big study, 15% of patients had impulse control disorder. It's common. So if you're on dopamine medications, you might feel impulsive. It's not uncommon that someone says, oh, you know, my loved one started buying lottery tickets. They never did that before. It's right, that filter on that frontal lobe just comes down a notch with dopamine medications. And then, so all it takes is that one little notch. And the things that you used to be, I'm not going to do that, you start doing it. Okay? So just keep an eye on that. So if you feel like someone's acting out of character, it might be something to discuss with the doctor, right? Because you might be able to just tweak the medication. There is something called dopamine dysregulation syndrome, and that's sort of the severe version of this. And that's usually someone that's gobbling up tons of levodopa. You know, we'll have a patient that comes in and they like go through their bottle in 3 days. And it's so impulsive. And so once it gets to that point, then, you know, of course we have to intervene. Impulse control disorders. I just threw in a list of sort of different examples of impulse control issues. So you can take a look at that later. Again, pretty much anything out of character, keep in mind, it's very likely to be disease related. I'm going to skip over these. So I wanted to quickly touch on non-pharmaceutical approaches because I really think a lot of these are where your best bang for your buck is. So you can get a lot out of a lot of these approaches. I won't go into super depth on them because I don't want to take too much time, but environmental modifications can go a long way. It's very common, for example, I'll just give you one example, sleep cycle disruptants, right? So you can get into a rhythm where you're taking a bunch of naps during the day and you're staying up late, you're watching TV, you know, now we all got smartphones. Apparently this age group is the most active on Facebook now, I don't know. So stop using it after 8 p.m. No more late night Facebook. So what's going to happen is your sleep cycle gets messed up, and when your brain is fighting Lewy bodies or any other type of disease, it doesn't have as much resilience to deal with, oh, I went to bed at 1, I took a nap at 2 p.m., that kind of thing. It's going to fall, it's kind of break down a little bit. So being much stricter about your schedule, your routine, and your environment will go a long way. And that's actually what I spend a lot of time doing with families and patients that come in. We'll optimize these things, and I'll say, if you can be very strict, and some of it's very hard, I understand, but in the best cases, if you strictly control environment, you can get off a lot of medication. A lot of stuff can just go away. And that's why often we'll see if a patient transitions, let's say, to a memory care facility that just can force that kind of schedule much better, many of the medications usually go away, right? A lot of the sleep medications, that kind of stuff. So I love doing this kind of stuff. Social interaction is extremely important. We're finding stronger and stronger links to dementia. So socialization, meaning we tend to see, it's very common, you start isolating when you get older for various reasons. It's really important to fight that and to stay involved. Retirement's a big trigger, right? Oftentimes someone will retire, but not necessarily have like something they're retiring to, and that's when I get worried. I want to make sure you really shouldn't be any less busy. You should be less stressed. You should be enjoying your everything, of course, but engaged, right? Volunteering, playing golf. I don't care what you're doing, but there needs to be a schedule and it needs to be full. Journaling, all kinds of relaxing activities count, but what I mean is, right, you have a full thing to do. I just don't want you sitting there watching TV all day. That's very common. Trust me, my dad does this all the time. Exercise, extremely important, right? The people that do best with Parkinson's disease, hands down, are the ones that stay fit and exercise later. They will recover better. They will stay more independent with motor symptoms. So I'm going to let Nate hammer that in. Music therapy has been found to be really helpful for for dementia in general, but Parkinson's disease dementia. So tons of studies actually on this. And in fact, you might have heard these sort of nice anecdotes where even like the movie The Notebook, right? Even the person that's can't remember, anything around them, and you play a song and memories come back, that's helpful. There's no reason to wait to, you do it earlier in life too. So listening to music that you really enjoyed is also very helpful. Cognitive stimulation therapy, again, very, very helpful, and there's different avenues to this. Reminiscence therapy, kind of going back and remembering. There's actually been some interesting studies where they'll do things and they'll build like they'll take over a hotel and build it up like it's from the 1960s, and they'll take people, elderly with dementia back in that, and all of a sudden their cognitive scores get better, because there's something to it, right? Bright light therapy, I recommend this very highly. So especially for us, we're living in Washington, we're relatively high latitude. So keep in mind, especially if you're having seasonal blues, sort of like, it's a little bit harder, lower energy, get a lamp. Just make sure it's 10,000 lux, meaning about that bright. And you want it, in the morning, it's got to be like right here. So you're kind of eating breakfast, reading your book on your laptop, and it's got to feel like the sun is in your eyes, ideally. And if you do that for 30 minutes first thing in the morning, you'll feel an amazing boost. It orients people that tend to get delirious to know that it's daytime, to lower that. Keep in mind, if you have underlying bipolar disorder or other sort of some other psychiatric issues, it's so effective that it can give you a little too much energy, and so you can get agitated. So if that happens, just then it's not. Don't use it. But keep in mind that can happen. And then indoor daylight exposure again. Just open the shades. Get the light in. Get the schedule on a routine. A few other things. They've actually studied Montessori programming for dementia, which is found to be helpful. I wanted to mention to you too, because I just went over some medication, non-medication treatments. You guys are all welcome to actually go online, and you can actually look. It's all studies are registered on the federal government's website, and you can actually search for trials. I've had many patients come to me and say, hey, I found this trial at Hopkins in Baltimore. What do you think? And we'll call, actually, and they fly out there. They'll do all expenses paid, and they'll go out and do the study. So people often will find studies that are good for them, and you know what? I highly support it, whether it's a drug trial or a non-drug trial. It can be an enjoyable experience. So keep in mind, any provider, I try to stay on top of it. It's hard. Within my little bubble, I kind of know pretty well what's going on, but keep in mind that no one provider is going to know how many exact Parkinson's disease trials are there out there. And APDA is obviously a great resource for that too. I put the website in the slide so you can search by state. Let's say you have grandkids in Florida. Well, look for Florida, right? Go find an excuse to go, and then make them drive you.
Can I ask a question?
Yeah.
Are there any at Evergreen currently that are
Cognitive?
Or
I'm trying to bring some in, not cognitive focused. Of course, many of you know there's a lot of motor symptom type of trials at Evergreen. Evergreen has something like 52 neuroscience clinical trials right now. So Evergreen's like one of the main spots nationally, which is great. But now that I have the memory, I'm trying to bring in more memory trials. There are a few locally though. So if you look up, there's a Lewy body dementia trial going, there's an Alzheimer's. So there are a couple, and I want to bring more of those local. Good question. I want to try to transition a little bit now to thinking quickly about prevention, and then I'm going to give you a bunch of resources that are in the slides that will help you hopefully in your appointments. Lancet commissioned this big collaborative effort in 2017 to look at risk factors for dementia. This applies to Parkinson's disease dementia. And I wanted to point out, of course, now if you're sitting in this room, it's probably too late to think about education early in life. There are things, of course, it's harder to control at this point. But ApoE, you might have heard a lot about that. That adds maybe 7% risk factor for Alzheimer's or dementia in general. Less education early in life is it's actually an 8%. It's a pretty substantial risk factor. Midlife, this is where we can start intervening and having a pretty big impact. So how many of us know someone with hearing loss that refuses to get hearing aids? Scare the hell out of them. Tell them, it's a risk factor for dementia. That's what I did with my dad, and he got hearing aids. And so hearing loss, 9%. The point is, if you have sensory organs that are not working as well, your brain's not going to be as stimulated, right? We want to keep the brain stimulated. Whatever that is, make sure your glasses are correct, your hearing aids are correct. So keep that in mind. Hypertension and obesity, this comes a lot with the fitness. It's substantial. 1 or 2%, if I told you you could lower your risk factor for disease by 2%, sounds small, but I don't know about you, I would do something. Late life, again, look at all these modifiable risk factors: smoking, depression, physical inactivity, social isolation, diabetes. So if you add all these up, you get to a pretty big number of some things that are very reasonably addressed. So the reason I put this up here is to give everybody hope, including myself, that there are things you can do. Even if you say, oh, it runs in the family, it doesn't matter. These are all things you can do. I just have a list here. I'll kind of gloss over this quickly. Caregivers, supporting caregivers is a major, major issue, especially as things progress, right? I have to remind people, I spend a lot of my time managing care so that the caregiver is taken care of as well, right? The vast majority, I think I had a number in here. I'll come back to that. Right, the vast majority of support for those with dementia, Parkinson's disease dementia, Lewy body dementia, is provided by caregivers that are not compensated, right? Some people have, in-home help, nursing help, or they go to an assisted living facility, but the vast majority is still by family members, right, and loved ones. And so if we lose that person to burnout, to depression, those things, that's a major issue. So we really want to stay on top of that. So I'm actually very forward about bringing this up early. As soon as, first time I meet you, I want to know, oh, how's your partner doing? And I talk to your partner, how are you doing? What's stressing you out? And I'm a fan of, giving you permission to bring in outside help, use APDA, come to these events, get support earlier rather than waiting. Because, all of us in life, we're used to waiting until we feel it, but that's probably a little too late. It's probably better to wait or to do it earlier. So I don't want to wait until you're burned out or feeling burned out. There's all kinds of respite opportunities. So a few other resources. I'm just going to get through a few resources. I have till 11:30, is that right? Hopefully that clock is right. Is that 11:30, right? Okay. Yeah. So we got together. So Washington State funded a Dementia Action Collaborative, so we got a plan together. I'm just pointing this out. They've already, well over 40,000 copies now have been distributed. Again, these are local, I'm talking about more local resources. There's national organizations like APDA that have local chapters that are extremely helpful. Washington's been funding dementia work. This is what it looks like if you've seen the cover. You might have seen this in clinics, or someone might have given you this. There's an online PDF version, so again, you can find this online. Again, if you have Parkinson's disease and you get a diagnosis of mild cognitive impairment or ultimately dementia, keep in mind, that doesn't mean you have to go to only right? You can look up Alzheimer's cafes, you can go to all of these things, because remember, we're not super good at diagnosing yet, so there might be something else going on anyways. No one's going to check your diagnosis at the door, right, and turn you away. So I want you to just keep an open mind, because you might find that, the Alzheimer's group has a garden walk, Sunday at 2 in Bellevue. That sounds nice, do that. So just keep that in mind. At the UW Memory Center, that's the only memory center in the state, we've been building up a lot of resources. So we have a really good crowd there that provides a number of outdoor opportunities. They're doing a couple research projects that involve taking you outdoors. A couple months ago, I went with them when we took patients to the ropes course just down the street in Bellevue. Really, actually, it was a lot of fun for everyone, but also very effective, both for caregiver and patient, helping you in many areas: socialization, exercise, cognitive stimulation. So again, these are some ideas I just wanted to share with you guys. There's a space actually near the Fry Art Museum on First Hill in Seattle. There's a generous donation by a family of the building next to it, and so that's being converted. It should be opening very soon if it's not open already. I have to double check. But that's going to be an all-comers welcome dementia open house. There's going to be representatives from various organizations. And it's meant to be a non-hospital, non-medical place for family and caregivers or patients with cognitive decline to come get more information or spend time. It's kind of a nice space for that. We can double check when that, but that was actually being renovated this summer. So I hear this a lot, right? So that's why I'm telling you here. So I'm going to keep going out to all these events and shoving this information as fast as I can, because the medical system is going to have a hard time spending enough time with you to really go over this. I get yelled at all the time because I spend too much time with you guys, and the hospital's like, you're losing money, and I say, whatever, and then I haven't gotten fired yet, so we'll see. But it's just the reality of it, right? I mean, we're hopefully moving towards value-based care. Systems are improving. Yes, that's happening. But the bottom line is, I need all of you to be champions and advocates for yourself and for each other, and also to help the community. I mean, it's really got to be a teamwork thing. And actually, people brought resources to me that I order and I put in clinic. So it's really a two-way street. So just the last few minutes, I wanted to, and these are things you can print out. They'll be obviously they're in the slides. So these are some things that you might even just be thinking about now, or you might have a friend, or you can help spread the good word. So when I think about, family needs assessment, I mean, these are sort of the things I go through with people. And often I'm lucky, I'm in a memory clinic, so I have social workers, I have support staff, so I'm very lucky. So this is the kinds of things that they will help me with. And I want to touch on all of these things because, first of all, many of them may not be obvious. Some people are, have already done work in some areas. Like some people are like, oh yeah, my son's a lawyer. We've got everything worked out. I've got a trust. I've got this. Great. I don't need to spend time on that. But there's always places we can improve. Again, these are kind of the important steps about addressing the whole family. By recognizing the need early, meaning I want you to be involved with helping come up with these plans while you, as the person with Parkinson's disease or Parkinson's disease dementia, has a say, right? I want you to be able to, I want to know what you want. Again, I just threw up some names and numbers. There's lots of resources locally. In fact, I've always been impressed for a state with no income tax and relatively, it's impressive resources here. It's actually a really nice place to live. There's a lot of ways to get help. So these are just some ideas, and I have the APDA information coming up too. Questions to ask. I just wanted to touch on this real quick. So I have some slides with questions that I commonly hear that I think are helpful. So these are just prompts. Obviously, you don't have to, come in with a sheet like this and scare your doctor and say, I have 100 questions for you. But these are things you might think, I didn't think to ask that. And so I'm just throwing these up here to help you understand, because it's a very complicated field. We touched on some of the confusion around the diagnosis today, but imagine for an average person trying to find me, right? You go to your primary care, there's neuropsychology. I'm a neuropsychiatrist. There's two of us in the state. There's very few that kind of go down this subspecialty route. So there's, primary care, then many of this happens in neurology or psychiatry, then there's movement disorder neurology, there's behavioral neurology, there's neuropsychiatry. So, it can get a little bit difficult to manage or to kind of navigate, but the point is, I just want you to understand what the differences are. Office policies really come in handy. At Evergreen in our memory clinic, the nice thing is there's a call pool, for example, so we're on call 24/7. If you're in a more advanced stage of illness and you're not in a facility that offers that might be something to keep in mind, right? Having access. So these are just some more things to keep in mind. Again, mostly this was here for you to review at your leisure. And then I put a little preparation sheet here so you can sort of have reminders and kind of have a little checklist. Follow-up visits, these are ways to be prepared with questions. It's pretty common, I obviously have my questions, but again, remember, I'm the sort of subspecialist, so I know how to focus in. But if you go to primary care or even a general neurology or something, it's going to really help if you have your questions ready to go. And you'll cover a lot more ground, because sometimes you have 15 minutes, right? And I want to make sure you get as much information as possible. Here's a little preparation sheet you can kind of print out. More questions you can ask. These are about medical tests. I kind of go through some different areas. Medical tests, diagnosis, medications, treatments, prevention, and then other concerns. Sensitive topics, I often will ask, hey, do you want to speak privately? And that can come up. Or as a loved one or caregiver, you might say, hey, you know what, I'm going to step out for 5 minutes. And you might not even know, and just say, I'm going to see what comes up. That's a nice thing to do. So providing some privacy, but again, some things are difficult to talk about. Again, these are more just leading towards wanting to be patient and careful with communication. This is all we're all trying to get to the same thing here. And often there can be family members that are just very anxious, right, or very scared. And it's important to recognize that there's good intentions behind that. So keep that in mind. I think it's really important. I try to write things and print them out for the visit, but keep in mind, it's sometimes a lot of information is being thrown at you. And I would say once in a while, someone will say, hey, I'm going to record this. I think that's a great idea. Feel free. More people should do that. Just record this, then you can listen to it. It's like a YouTube video with like a ton of information. You pause it, right? You rewind. We do that for a lot of things, but the clinic visit tends to just go by, and then you're wondering, well, I don't even remember what was said. So, and you can ask for copies of your records, but keep in mind, a lot of doctors' notes are not very good after the fact. I'm just going to skip through a couple of these. These are more for you guys to look at afterwards. Some websites. I threw up some information again up here. So a little bit heavy on the resources. I just wanted to get through in our time allotment. But keep in mind, the people I see going through this process that I'm able to help with, it's extremely rewarding for me, which is why I do it. I very much enjoy it, and I see really good improvement in many areas, and I'm often amazed at how rewarding it is and how thankful people are with these when they do follow these steps or have these resources. So keep in mind, there's a lot of good stories out there. And then if you have any questions, I just threw up my information here. Go ahead.
If you're kind of early in the process, a fairly new diagnosis, say, and you're noticing minimal symptomatology of what you're talking about, does it make sense to get a neuropsychological evaluation for like a baseline?
Yeah.
And is it normally covered?
Yeah, it will be covered. Luckily, with Medicare and most private insurance, once you get to that point, go ahead. Oh, sorry, the question was...
Reminder.
I'm sorry. The question was, if you're early in the process, just having the very early signs of maybe cognitive decline, still maybe fully functional, does it make sense to bring that up in the clinic, get a neuropsychological assessment, one of those multi-hour batteries I talked about? And I would say yes, that's actually the best time to do it, because they can really dig in and see the patterns and say, okay, this is a little more suggestive of Parkinson's disease dementia versus, no, this is actually all just normal aging. So that's the time to do it. In fact, the neuropsychologist will get upset with me if I try to send someone who's further along, right, because it's harder to test. But yeah, so that's a good time to get a baseline, and then it might be 5 years later, things kind of don't change, that you do it again and say, I see this pattern. So that's when it's most handiest to establish a pattern over a few years. Good question.
So you're talking about doing the full
Yeah.
assessment versus just the little...
Exactly, because for many of us, for you guys, really, yeah, if you're early on, you're going to keep getting 30 out of 30 on the MOCA, and it's just not going to really, nail down what that baseline is. So it's definitely a good thing. There's a lot of research right now about how to make the neuropsychological testing more accessible too, because it's long. It might have a wait list of a few months just because it's they can only see one patient a day, so it's slow. Any other questions? Wow, everyone's an expert? All right. That was easy.
I assume smoking means if you smoke, cut down, or
Yeah.
don't start.
If you smoke, definitely don't, if you don't smoke, don't start, please. Yeah, but cut down as much as you can. And if you work with your provider, there's a lot of ways to help you now. You don't have to cold turkey it. That's how, the only option you had many years ago, but there's lots of other options now. Nicotine gum, that kind of thing. So definitely good to bring up.
Just briefly talk about the difference between hallucinations and delusions.
Yeah, so there's an umbrella of psychosis, and don't be scared by that term. It's just referring to these alterations in sort of reality. And so delusions are your beliefs. It sort of tends to be a fixed belief that's departure from reality. And what's reality? I mean, I don't know. It's what everyone else around us is saying. But delusions are things like, oh, my neighbor has been watching me with binoculars all day, and I think he's like pointing a gun at me. I never, ever tell someone they're wrong, because, trust me, I've been surprised, right? But all you can do is have open conversation, say, wow, really? I would be terrified if I thought that. Be empathetic, be open, and you look into it as best you can. And I might sit there and say, well, I'm looking, I don't want to disagree with you, but I also I don't see it. And then at that point, you can just kind of walk away. And that's more of like a delusion. I'm just throwing in some ways to deal with it. Hallucination is a sensory stimulation that doesn't line up, again, with reality, meaning your eyes are seeing something that others are not seeing, your ears are hearing something, so it's coming through those senses. Does that make sense?
Yeah.
Okay, good time to probably hand it off. All right, you know how to reach me if you have any other questions. Thank you, everyone. Thank you.
Take the microphone.
Did I embarrass you?
No. Okay, so we are going to take about a 10-minute-ish break. Before we do, I want to go over a couple of things. There are snacks and water. Please take whatever you want. I don't want to have to take them back to the office, so, if you can keep me from carrying them, that will be great. There are restrooms over here. There are also restrooms inside the Mercer Island Community Center, so you can use either one. I want to thank our two sponsors for this program, Amneal and Abbott. They both have tables here with some information to share, and our sponsors really make these kind of programs possible to put on. They help us, provide the space and provide food and get the information out. So thank you for being here and sponsoring this program. So we will gather back in about 10 minutes, so at 11:45. What's going on at APDA, and tell you about some upcoming events and some new information, and just a little bit about what we do as an organization. So super briefly, we are a local chapter of the national organization, which is the American Parkinson Disease Association. And our mission is to every day provide the support, the research, and the support, the education, and services to those impacted by Parkinson's disease so that they can live their best life. So we are kind of dual focused. We want to provide hope for today through services and education, and then we would help for today and hope for tomorrow through research. So we kind of do a little bit of everything. So we have some really great education programs coming up. This is the first, like I said, in a 5-part series. The second one is going to be in March, and that is going to be on basically exploring housing options, whether it be aging in place, whether it be a retirement community, assisted living facility, independent living, those kind of things. But how do you make those choices? How do you ask the questions? How do you tour? How do you plan for the future just in case you maybe want to move from your home? Or how do you stay in your home? What are your options? So that's one of our speakers, and then the other one is maximizing your home health benefits. So I've recently just learned this, but there are a lot of home health benefits through Medicare and through different insurances, and they are underutilized in the system. So there's a woman who's going to come and talk about what are those benefits and how do you maximize them so that it leads to greater health. So that's the next one coming up in March, and then we will have have 3 more as the year goes on. There's also some other great programs coming up on Friday, April 24th, and there's flyers in the back. This is down in the Pierce County area, but it is going to be a program called Live Well South Sound. And our medical director, Dr. Rebecca Gilbert, who is in New York, is going to come out to the Northwest, and she's going to be our keynote speaker. And we're going to have a morning of lectures and then an afternoon of breakout sessions, and it's all designed for people who are impacted by Parkinson's, and there's a great lineup of speakers and topics, and registration is now open on our website. And space is limited, so I encourage you that if you want to take the trip south, that this will be a really great program. We will also have another Live Well event in August that will be in Bellevue, and it's all going to be about movement and wellness. Our keynote speaker will be Dr. Lori Mishley, who is a naturopathic physician, and then the rest of the event is all about movement and wellness. So we might have Tai Chi, and Nate might be there doing his AMP classes, and we might have juggling, and just different things that are good for people living with Parkinson's, and it's all about movement and wellness, things that you can do for yourself. So no information about that is up on the website yet, but it will be soon. So those are a couple of things that are coming up. We also have a fantastic and wonderful fundraising event coming up in March. There's some save the date postcards. March 14th is our annual Magic of Hope Gala. It is an auction, it is a dinner, it is a party, it is a really, really wonderful event that raises money to support the Parkinson's disease community. So that's coming up in March. And then save the date, our big Optimism Walk is coming up at the first weekend in June. It will be on Saturday, and it's about 700 people coming together to raise money and support the Parkinson's disease community. And it's a party with a walk problem. So we have a little walk, it's there and back, and then we have a party afterwards. So information about that is up on our website as well. So those are some things going on. It's going to be an exciting year. Stay tuned to your email and your mailbox, which will tell you about the different things that are coming up. So without further ado, are you ready?
That's a good time.
I'm going to pass the lapel mic to my friend Dr. Nate Coomer. Dr. Nate Coomer is a doctor of physical therapy, and he founded this really cool resource here called the Parkinson's Fitness Project. And it is very, very much focused on wellness and fitness and therapy for Parkinson's disease. And so he is going to talk about what's the link between cognition and exercise. And he's probably going to get you up and moving. So thanks for being here.
All right. We made it. I was under the gun there, but I think I got my Instagram account up so you guys can see some videos too. How are you guys doing?
Good. Fine.
How's my lighting, Kirsten?
Good.
I'm on, all lit up, looking pretty. So it's nice to be with you guys. As Jen mentioned, I hope I can piggyback on what Dr. Ghomi had to say. Really great talk. It's amazing as I do more of this, how many people are dealing with some of that mild cognitive impairment. And that's where I really feel like we can have a benefit with what we're going to talk about today with exercise and cognition. I have a very well-rehearsed talk on exercise for Parkinson's disease. Today I get to take it a little step farther and kind of drill down into exactly cognition with exercise. So I'm going to introduce myself, and then I want to learn a little bit more about all of you. I see some familiar faces in the crowd, but I don't know all of you. Hopefully I'll get to meet you all by the end. But I'm Nate Coomer. I've been practicing as a physical therapist for about almost 15 years now. We moved out here in 2012, and I was lucky enough to be in a position where I was working with neuro patients with mostly Parkinson's disease, and that was the first time in my life where I felt like I had a real important role to play in a person's health throughout, their lifespan. And it was really rewarding for me. I felt really passionate about it. I love the people that I work with. I love working with you people. And so I decided to do it in a way that I felt the research showed was most appropriate. And we started the Parkinson's Fitness Project a little over 3 years ago. We have a couple clinics over in Seattle. And I also have some letters behind my name. They're just certifications that say I've done some training to focus more on Parkinson's disease as well. And then that PT, DPT is just physical therapist, doctor of physical therapy. And then the NCS was a clinical exam I took after I got my my doctoral degree, because I knew I wanted to work in neurology, and it's an exam that shows that you kind of have a good breadth of knowledge on all things neuro. So that's a little about me. This is a little about our clinic. It's fun, right? That looks fun, huh? This is, my kids, Jenny's kids. She's a therapist that works with us too. We're kind of a big family. These are our classes. There's a couple people that hang out with us in our classes here today and come to our classes. So thank you guys for coming. Both clinics. This is our First Hill clinic in our class. Franz, she does our training over there. Jeanette, she's our office manager. She's my mom. She takes care of all our billing and everything else. She's not really my mom, but she's my business mom. And then this is us working out with Kelsey, our other physical therapist. We do an online training that's a lot of fun and give people resources to use from home wherever they are. I'm sorry if I'm shaking. I'm like freezing, and there is a blower right on me. I can't believe Dr. Reza, Dr. Ghomi was right wearing his jacket. Jeez Louise. So objectives today, I want you guys to learn a little bit behind the research of exercise, but really exercise and why cognition with exercise is important. Understanding how cognition affects balance, understanding the specific areas of cognition that are important to train for reduced risk of falls, demonstrating examples of cognitive training with exercise. So real quickly to point out why I'm talking about balance and falls. Cognition is highly associated with falls. I'm a physical therapist. My main goal in life is working with any of you is to keep you on your feet for as long as possible. Because if you think about it, most people that are able to walk and do so independently have a pretty high quality of life because they can stay independent as long as they can. Parkinson's are not. However, any aging population, I think, would say, or anybody that's getting older would say, I want to stay on my feet and be able to move where I want to move, and that keeps me independent and feeling good. If we can keep your cognition strong and keep you physically fit, the hope is that you'll continue to move longer without those falls or worries about balance that put people into a position where they have to use an assistive device or maybe not go where they want to go. And that's limiting. And that reduces quality of life. So that's why we put so much importance on cognition and exercise. And then I want to demonstrate some examples because that's fun and nobody's going to fall asleep and everybody's going to have a good time and you're going to understand a little bit more about how cognition plays a part in exercise and how you might be able to do so at home. Now, how many of you are exercising right now? Yeah, buddy. Everybody's raising their hands. Thank you so much. Good job. What are you doing? Give me some shout outs. What are you doing for exercise? Weightlifting. Rock steady boxing. Where do you go?
North Shore Senior Center.
North Shore Senior Center. Up north. Yeah. Do you work out with, who do you work with? Shiggy?
Jolene.
I know, okay, Jolene, yeah. Anybody else? What are you doing for exercise?
Gym 3 times a week, bicycle rides and walks.
Bicycle rides, walks, gym 3 times a week. Good job. Outside of the bicycle rides and walks, you're going to the gym 3 times a week. What do you got?
I go to yoga class with Jolene.
Yoga class with Jolene?
Peter Lynch.
Oh, Peter Lynch. Great guy. He gives a great class, doesn't he? Up at Evergreen, or do you do it somewhere else? Okay. So lots of different variations. What are you doing for exercise?
Stationary bike at
Stationary bike at home, getting your revolutions per minute?
Just series of different exercises. Some for legs, some for
Good.
arms.
So everybody's got the message that exercise matters, right? Now, if I was giving that speech 10 years ago, I don't know that so many people would have raised their hands. When I was in PT school, it was just a matter of saying, with Parkinson's disease, you want to keep people limber, keep them healthy, make it easy, you don't want to push them too hard. Things have definitely changed in the last 15 years, really, with the research. The research was already out there, but the field hadn't changed. And I never would have been able to start something like the Parkinson's Fitness Project if we didn't know so much about research and you guys weren't so proactive about keeping so healthy and physically fit. How many of you feel like you've learned really about cognitive challenges and how cognitive training plays into exercise? Have you ever heard a talk on that before? All right, new, fresh material. Okay, so that's what I hope to do today. First off, why is exercise so important? Exercise matters in a number of ways. Dr. Ghomi touched on a few of them. Number one, it just releases a ton of endorphins that make us feel good, right? When we exercise, we feel good, we feel better, we're able to attempt things that we maybe would normally or feel better about approaching the day. There's a lot of special things that happen. I'm going to try to keep this as basic as possible so that everybody can understand it. But by and large, we have some really specific things that happen in our brain when we exercise and when we exercise hard. So neuron size and speed of transmission increase. So those nerves that are sending signals in your brain actually can increase the speed with which they, which they change slides and the speed with which they can transmit signals. Very important when we're talking about cognitive processing speed and keeping our mind sharp, right? Increased corticomotor excitation. So the area in your brain that's responsible for movement gets more excited. Really, by and large, the areas that we want to be more active in the brain become more active with exercise. And so one of those being our area of movement. We get more blood flow into the brain. If you think about blood and what it carries, oxygen, nutrients, to bathe our brain in the things that we need to keep our brain as healthy as possible living with this disease, blood flow is very important. And the more blood flow we can build up in the brain, the better. A lot of times I like to describe Parkinson's, people don't always think about it as such, but if you think about it as a total body disease and inflammation within your brain, really, because of all those Lewy bodies that Dr. Ghomi was talking about, and your body trying to get rid of them, you really have an inflammation that's going on, and we see decreased inflammation when we exercise. So we can keep the brain less inflamed and healthier and better able to operate instead of trying to attend to all the other tasks of trying to clear out all the garbage that's in there associated with those Lewy bodies. Brain-derived neurotrophic factor is BDNF. That's a protein that keeps our nerve cells happy, keeps those nerve cells transmitting safely, and we see increased serum levels when we work out, which is just basically blood levels of BDNF when we work out. Our immune system function improves, so talking about decrease in inflammation, all those things we see improved immune system function, and bigger than anything, dopamine receptors are increased. Those receptors that can take in the dopamine that you have out in one nerve trying to send the signal across to the next within your brain are increased, so there's bigger nets to catch the fish, right? So the dopamine that we're using, sometimes it gets lost out there when we try to transmit a signal from one nerve cell to the other. Bigger dopamine receptors take more in so that we can use the dopamine better and more effectively. I always describe, well, got a burnout bulb, I'm too hot. Dopamine receptors it's kind of like we run better, more fuel efficient when we have exercise in our life on a consistent basis. It's like going from a Hummer to a Prius. You're not guzzling gas or dopamine when you're exercising regularly and consistently. You use less gas, so you move to a Prius or a Tesla, I guess, nowadays. Healthy brains recover faster and can do more with less. That's really, by and large, what I want you to think about. Healthy brains, healthy bodies can do more with less, whether it's dopamine that we're talking about in this case specifically. So we use that dopamine that we have left in our body more effectively. Why cognitive training with exercise? Quick question, how many of you are dealing with like a shuffling gait pattern or feeling like you shuffle at points in times during the day? Yeah, thank you for being honest. It's a symptom of the disease for some. How many of you felt like you get frozen? Maybe at night, maybe when you're off meds, those types of things. A few people, a few hands. So that's one of the biggest things that was one of the biggest light bulb moments for me as a therapist, is when I was taking training for Parkinson's and realized some of these things that I didn't think there was any real cure for or way I could improve them. There's actually good research to show that some of the things we do and specific cognitive training with exercise can be effective at slowing, improving gait and decreasing falls and freezing and shuffling of gait, which are huge problems for people when we talk about staying on our feet for as long as we possibly can and walking independently. So cognitive training is really important in that aspect. We also see a big decrease in falls just overall. When people are thinking and moving at the same time, we see a decrease in falls. If you think about it, the world is cognitively and physically challenged. I was just shooting a video yesterday for Brian Graham Foundation, who's down in Portland, just to give some tips for training. And that was one of the things I thought about and I said, you know, the world is stimulating. You guys are going to walk out of here, there's going to be 30 of you that are going to walk out that door, and you've got to all meander through it, right? And you've got to wind your way around the chairs and think about where your car is and think about what you're going to do next when you go leave here and go get gas or go take a nap because we tired you out so much. But you're thinking about a lot, you're processing a lot, and you have to move through this world with something on your mind all the time, pretty much. We need to challenge you the same way when we exercise. It cannot just be something where we're, you know, kind of rotely going through the motions and not thinking about it at all. It should be a complex challenge for you. And there's ways to make it complex I hope I can show you today. Improving, we've seen that we can have improved processing speed, part of that signal processing that I talked about from nerve to nerve. Improved balance, obviously with decreasing risk of falls. It's just such a huge thing. Falls are such a big problem with Parkinson's disease and overall our overall population as we age. So improving balance is so important. Being able to prioritize is something that we work on a lot and something that does show to carry over when people are focused on it when they're exercise. Making the determination whether something's safe to do or being able to hold back and protect themselves and stay safe. Prioritizing the cognitive process or the physical process. I'm walking and having to count numbers. I want you to focus on your feet. Stop counting if you feel like you're getting unsafe. Being able to do those things in real life is important. Walking around in a crowded environment and knowing your limits and being able to stop, have a conversation, prioritize the conversation, but still have an eye on where your balance is and where people are around you is something you do every day. So we need to train it. And then visuospatial improvements. How many of you have trouble with, this is the best one. One of my clients said the reason he knew he had Parkinson's originally was because he had trouble backing into parking spots. And I'll always remember that. Has anybody, can you connect, right?
Parkinson's Parkers.
Parkinson, yeah, you need double. You need double wide. You need double wide spots, right?
If it's a totally empty parking lot, that's the worst possible situation.
Is that right? To get it between the lines. Yeah, that's funny. But that was really interesting to me that he said the first thing I realized wasn't a tremor, it wasn't like I was slowing down or moving slower, it was that I couldn't back up anymore. And those visual spatial challenges are way more prevalent than people talk about. I bet most of you can think about things that you do that are just not as easy as they used to be, whether it's trying to plan the task out. I'm thinking of like putting on jackets or even parking in spaces, meandering through chairs like this. Those visual spatial impairments are something we need to work on. We'll show a few examples of that or have you demonstrate as well. So, cognitive dual tasking is something we obviously work on a lot, thinking and moving at the same time. These are the main areas we try to hit on. Does anybody know what set shifting means? I don't assume you do, but maybe you do. So we're going to have everybody move. This is one of my favorite ones. Jen's seen me do it 100 times. Some of you have probably also done it, but this is a great example of set shifting. You don't even have to move out of your chairs. You can all sit. Just don't punch the person in the front of you with your fists. Maybe be a little lighter on the fist today. So we're all going to put our hands up. We're boxing, right? You said you do rock steady, you know rock steady. Now this is not a rock steady drill, it may be in your class, but I want you to just put your hands up, and if I say right, you're gonna punch with your right hand. Right. Good. Now I want you to say it with your voice. So right. Right. Yes, nice loud voice from the bellows. Right. Left. 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 Right. Right. Left. Now you have to do the reverse of what I say. So if I say right, you're going to punch with your left hand. However, your voice is still going to say what I say. So if I say right, your voice is going to say right, but your hand is going to be the left hand. You got it? All right, I'm going to turn around so I don't confuse you or myself. We're going to do the opposite with our hands, but say the same with our voice. Ready? Right, right, left, 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 right, left, right, right. I almost confused myself. Nice job. As soon as I started to get the chuckles, I know I did good enough. So that's set shifting. I'm making you think about one thing and do another. You have to flip that in your brain. It's like rubbing your head and patting your belly at the same time, right? It's a cognitive challenge, it's complex, but that happens in real life. You're walking down the hallway, you go into your doctor's office, you always know it's down this hallway and to the right. I'm talking to my spouse or loved one. I'm walking down, going to turn, and I see the sign and it's pointing the other way. I have to shift my motor plan and go do another one instantly, quickly, and with quality, right? You have to be able to change directions quickly in life depending on what the signals are that are given to you. I'm giving you signals, you're changing and flopping and flipping based on my rules. We need to challenge that. We need to practice that, because what happens when we're not prepared? A loss of balance, right? And like I said at the start, if I can keep you on your feet, I'm doing my job. There's a lot of other things that come along, positive benefits with cognitive challenges and cognitive training, like Dr. Ghomi talked about, but as a physical therapist, that's my main concern. And so that's why we do it. But it's also kind of fun. So we work, now you know what set shifting is, we do that in many different ways. I'll show you some examples with video, and hopefully we'll get you to practice some as well. Short-term memory, pretty obvious. We're trying to make you recall tasks and things quickly, or giving you lists, those types of things, while you're doing a physical task. It becomes more complex. One of the things we want to achieve with exercise, your weightlifting, you want it to be intensive. You want it to be hard and complex. Adding these cognitive drills in makes it complex, even if it's like short-term memory. Which rock steady, you've got to remember the combinations. Great job of that. So that's what you're working on when you're doing it. Inhibition. We talk about inhibition training a lot. We're going to do the same movement with the hands that we just did, but this time you have to wait for my cue and hold back. How many of you, I've had a few clients who've said they've actually had falls because they couldn't stop themselves. They went for a hike and got going, and we're going back to the car, and they couldn't stop themselves, and actually you couldn't stop to get to the car. You're shaking your head. You must have, do you have an idea of what that feels like, or know somebody? Yeah. So what is that? What's with that? Like, I couldn't even stop myself. We talk about Parkinson's as this like difficulty getting going and a slowness of movement, but it carries over into not being able to stop the movement, right? That's inhibition. And I use this example, and I think it really, most people can really understand what I'm talking about. You go to step across the street. Our First Hill Clinic is right downtown. It's on 7th and Madison, right by Virginia Mason. And I've done this a couple times. There's a stop sign, stoplight, there's a bunch of traffic. I get my walk sign to go across the street. I start to step out, and I can see there's a biker that's looking like he's going to turn, and there's also an Uber car that's coming toward me. Doesn't look like he's going to stop. The lights are saying red, my sign's saying walk, but these guys are coming toward me, and I've already started my motor plan. Can I stop it in time, right? So can I stop, pull back, and stay balanced and focused, and not get ahead of myself and lay out in the street or whatever happens. Those are real things that happen with Parkinson's, and we've shown through research that we can actually slow that down if we practice inhibitive training. So now your dukes are up again, everybody's up, ready to brawl. No reversals this time, so you don't have to think about anything. If I say right, you punch right. I'm worried about you. I'm getting out of my way. She looks like a tough one. So if I say right, you punch right, but you have to wait until I say go. That's your only rule. Okay? Ready? Right. Right. Gotcha. Already. Yes. First one. Never miss. Right. Go. Right. Left. Go. Left. Go. Right. Go. Right. Go. Left. Go. Right. Go. Left. Go. Right. Go. Right. Go. Left. Go. Right. Go. I saw you in the blue. You were chomping at the bit, right? But that's what we want. Your motor cortex said, ready to knock him out, and you held back, right? You didn't throw the punch. We can play around with timing, play around all kinds of different things with inhibition and make people feel like they have to take that step and then wait for a signal to hold them back. And that's important because now you can kind of relate. You see, like that feeling of like, just stop, get me back on my heels, right? We work on that all the time. It's an important part of cognition. Most people just say, oh, my balance is no good. That's a cognitive task. We need to practice those cognitive tasks. We can be more specific than just saying, my balance is shot. All right? So that's inhibition. Sequencing. Everybody gets to stand up now. Jen said there wasn't going to be enough room. No way. Not now. If you have balance issues and you don't feel comfortable standing, you can still do all these motions with your hands. So feel free to stay seated. I like you guys. Everybody's up. Now, you can hold onto the chairs in front of you so nobody's going to have any falls. All right? I always hate that. When half the crowd falls down, that's never any fun for me. So we've got some simple movements now. I've got 4 movements. We're going to go hands out. Hands out in front. That's 1. We're going to come back, hands back, squeezing those shoulder blades, right? Nice and tall, chest up, head up if we can. Good job. Now we're going to say power up as we do that. So we're going to come back and we're going to say power up, out, power up. That's the first movement, power up. Next one's a weight shift. We're going to reach our hands from side to side. Nice big movements. This is something else we talk about with exercise, but we're going to go from side to side 4 times. We're going to start going to your right. So is everybody ready? We're set, hands together like we were with our boxing, and it's over. 1, together, 2, together, 3, together, 4. Easy. That's your second movement. Third movement is a punch across your body. Now nobody hits their partner in the cheek, okay? So it's just a reach across. That's right. And I want you all to start going to the same side. So we're going to punch toward this side, okay? So ready? 1, together, 2, together, 3, together, 4. What was your first movement? That was the hands forward, power up. Hands forward, power up. Just 2 times. And then it's a weight shift. 1, together, 2, together, 3, together, 4. And then it's a punch, right? 1, together, 2, together, 3, together, 4. Now let's all keep it going. Ready? I'm not gonna tell you what's coming next. We've got 1, 2, and 3 movements. We do the first one twice. The second 2 are 4 times each. Ready? Out. To get up. Out. Power up. Together. 1. Together. 2. Together. 3. Together. 4. Together. 1. Together. 2. Together. 3. Together. 4. Back through it. Out. Power up. Out. Power up. Together. 1. Together. 2. Together. 3. Together. 4. Together. Punch. Together. Punch. Together. Punch. Together. Punch. Yeah, give yourselves a round of applause. You can sit back down. That's sequencing, right? Were you thinking about what movement was coming next? Were you saying, well, I don't want to look like an idiot out here, everybody else knows what's going on? That's complex. That task was not necessarily hard, although thinking about the size of movement and changing your body and changing directions can be hard. But the cognitive process of sequencing out those movements is really complex, right? So that can be a cognitive exercise in itself. And when it comes to things like getting out of the car, processing getting out of the shower and shutting the door behind you, getting in and out of the house and shutting the door behind you and making sure you place your feet right. Those things can sometimes get very difficult for people, and that's sequencing. Go ahead.
Isn't dancing like sequencing?
Yeah, and we got a good dancer in the back. If everybody wants to say hello by the end, the man in the back over on the left is an unbelievable dancer. I think a woman on the right can attest to that. She was doing your moves in class yesterday. She was biting off of you. She was doing the shoulder roll. But yes, that is sequencing. That is amazingly powerful. So if you're having trouble with sequencing at home, not being able to put one task together with the other, or kind of mushing movements together, that's where dance can really be a great exercise specific to you. Visuospatial awareness. You're all gonna stand up again. Here's what I want. We're gonna step in multiple directions. I want you to feel comfortable stepping either backward, to the side, or forward. If you don't feel comfortable with that, you can use your hands, okay? So you can stay seated. Anybody that feels comfortable with that, join me again. So we're all gonna stand up. We're going to imagine we're standing on a clock. Now this is visual spatial awareness. You have to imagine in your mind what's below your feet. We're standing on a clock, just like the one behind us. 12 o'clock is straight ahead. Does that make sense to everybody? Give me a yes. Yeah. That's what I want to hear. All right, we've got 12 o'clock. Then what's over here? Woo! They're on it today. What's over here? 6 o'clock. What's over here? 9 o'clock. So let's practice stepping in those directions. If I said 12 o'clock, we'd step forward and then come back. I don't care which foot you step with. We're going to step forward to the 3 o'clock. 3 o'clock's a side step. How about 6 o'clock? Stepping back. Whoops, you got it. Together. 9 o'clock. Good. How about 2 o'clock? Good. How about 7 o'clock? Good. How about 9 o'clock again? How about 10 o'clock? Good. So we've got all these times down. Now think about on a clock, you have an hour hand and a minute hand. So if I were to say 10:30, I want you to step first to the hour hand and then to where the minute hand would be. So if I said 10:30, 10, together, 30, and back. Does that make sense? We'd step to the 6. Give me a time.
6:30.
6:30, let's do it. So we're going to step back, together, back, together. Give me a time.
8:40.
8:40, let's do it. 8, together, 40, together. How about 2:30? Ready? So we go to hour hand first. 2, together, 2:30. So you can play all kinds of games with it, but you see how visual spatial memory comes into play. You're having to take something in your brain and put it at your feet. There's a very nice app out that's very simple. It's called, you can sit back down. At ease. At ease. There's a very nice app out right now. I don't have it on here. It's called Clock Yourself. Clock Yourself. That's it. Just the Clock Yourself app. And it's exactly this kind of stuff played out on an app. They give you all kinds of different drills. Well, it's all based on clock patterns, but they give you different challenges with it as you progress. So you might have to do arm pumps as you step out, or bicep curls, or things like that. So I think it's maybe $1 or $2, but it's a really nice app, and it's really one of the first things out there that kind of takes into this visual spatial training. Okay? So, cognitive dual tasking. We know gait and balance require executive function. I only have till 12:30, don't I? I'm going to skip over this. We'll just do it quick. Gait and balance require executive function and cognition. We need to process and move at the same time. Freezing and falls are associated with lower cognitive scores. So, all the more reason to work on your cognition with exercise and also, outside of it. But really adding it into functional training. We're physical therapists. We work on what people have trouble with. We need to work on processing and moving at the same time. And I'm a really big proponent of trying to find someone who can help you in these matters. Lots of physical therapists out there, very few of them have a neurologic specialty, even fewer have a Parkinson's specialty or go to the link to try to look at this research. We're lucky in this city because we have quite a few movement disorder specialists who have connections. If you haven't gone to see a movement disorder specialist, get there first. Tell them about some of the movement problems that you're having. Explain to them the movement problems you're having. Too often I hear a movement disorder specialist doesn't refer until you've had a fall. We need to get at it earlier than that. We can really prolong your health and your longevity if we can start working with you early enough and adapt to these cognitive drills to your problems, right? Practicing cognition and mobility at the same time is real life. So if you feel like you might fall into one of these categories, mild cognitive impairment, feeling a little hazy with things, just not quite as sharp as you used to be, getting in and working with a physical therapist who has some experience with neurologic disorders can start to tease some of these things out. And like you said, boy, your issue really lies in sequencing. That might be where dance would be the best exercise for you. You know, sometimes people just are told to go, exercise when they go to the doctor's office. They're not really told what's a customized program to your specific issues. And as Jen said before, it's a snowflake disease. Everyone's different. So you need somebody with kind of more trained eyes and to spend a little bit longer with you to really tease out where you could spend your best bang for your buck, I guess, in better terms, in terms of exercise. And that's where we come into play. If you're working with your hospital system, there's some great therapists at Swedish, Evergreen, you could get in with them as well. But that's what we're trying to do, is give people more of a customized approach to their exercise routine and stay with them. I want to show you a few examples. You guys have gotten some demonstration. We've got about 5 minutes left. I'll get you out of here quick. But I want to show you a couple examples since I tried to pull up Instagram. Hopefully it'll work. So this is an idea of set switching. Maybe. There we go. Oh, whoa. Never mind.
You can just press escape and you should be able to get the PowerPoint away.
Oh, thank you.
And minimize it.
Actually, these should be clickable links, but maybe I'm wrong.
Right-click it, put your mouse over it, right-click it, and say open hyperlink. It gives you that option. It opens tab, hyperlink.
Well,
let me see if I can do it. Keep talking.
Yeah. Really quickly, we don't have much time left, and I'll take some questions and answers. I hope I gave you some information on how cognition can be helpful with exercise.
I think it's here.
Okay. Let's see. So this is a great example. I'll play this one for you. This is from our AMP class, and this is moving in a crowded setting. We have these lights. They all are, one person has one color, so they have to find their color and turn it off. And they've got to move through a crowded setting and situation. There's Riley smiling in the back. But you can see how this is like real life. Big movements, make quick turns, and get around whatever variables are coming at you. Have to process and find your color in real time.
Really hard.
Yeah, you might see Alana in some of this. Here's dance. This one, you can go ahead and play it. We had a great class a few weeks ago where we were led through sequencing, and it was extremely challenging for folks to keep with 4 or 5 skills at a time. 1, 2, 3, 4. 1, 2, 3, 4. It was really difficult. It can be much more complex than you give it credit for. And there's reason why dance. A lot of people say, it's just dance. It's the sequencing. It's the complex process that takes place that's so important. We can click out of there. This one. You're getting all kinds. This is another great, well, let's go. I won't take too much longer. Let's see. Complex processes, stepping over different hurdles and different challenges. So having different balance obstacles that you have to stay on and being able to step in a patterned sequence. This isn't so much, I want you to remember 5 things, but you have to process in real time. Where am I going to put my foot? What comes next? Which foot do I go with? Which foot where do I step to? Stepping accuracy, visuospatial skills, being able to step accurately and find your balance. And I need my Mac back. Oh, what else do we have? Got some good ones down here a little further. That's my son. Let's see. Keep on going. Got too many. This is processing in real time. This is just a PowerPoint presentation with different arrows. When it's red, he has to you have to reach out to the opposite side. When it's blue, he has to reach out to the side that it's pointing to. So that's that same set switching, but you're moving in real time. So you see how we take functional tasks and make them more complex with a cognitive drill. Does it make a little more sense to you now? Because I think a lot of times people say, oh yeah, you should have cognition in there. But you're like, how? I don't know how. What am I supposed to do? Do a crossword while I'm on the treadmill or while I'm riding the bike? Maybe, but we can customize it better to fit your needs, okay? You can go ahead and go back to the PowerPoint. I'll just put up my last slide. We do, or actually, yeah, so this is just a little bit about us. We have 2 clinics in Seattle. If you want to come by, please come by. Our cards are on the back. You can set up your name and we'll contact you. We take insurance for physical therapy. We take Medicare. We're a staff and a team of 3 different therapists and 1 personal trainer. And Riley, and our student, she's in the back. We actually have some good news. In March, we're going to open up a 3rd clinic on the east side. So if anyone is interested in receiving physical therapy or training or classes over here with us, we're going to be up off of Bell Red Road and 140th. So we're really excited about that. We hope it's something we can bring over here because we've been really hoping to get over towards this side and give a little more resources for people with Parkinson's. We also have something online if you're not able to get in and get around, or if you feel like you want to work out more often from home with a lot of cognitive training on it. It's called Daily Dose PD Online, or dailydosepd.com. It's in the back. You can check it out. The website's just www.dailydosepd.com. We put up 3 workouts every week. They're live streamed, but then they're recorded and you can take with you. They focus on all the key tenets of what Parkinson's exercise should be, and we have a chair-based class, we have a moderately based class, and then a high-intensity class to try to fit everyone wherever they are. And those are all recorded for you to use via app, Apple TV, Smart TV, or just through the website on a computer. And my information is right here, the website's right here, the card's in the back. Please sign up if you have any questions, and then if you ever want to give us a call or write me an email, I'm right there and I'm pretty easy to get a hold of. I'll write you back same day, promise. Okay, does anybody have any questions for me?
Curiosity is like length of time you spend on the different parts of these things. What kind of time length?
Exercise should be, yes, exercise. This is part of my general speech, but really we're looking for, the research shows at a bare minimum 150 minutes a week of moderately intensive exercise. It does not count if you're walking and talking and hanging out and you're not having trouble breathing. You're just going for a light gingerly stroll. I wouldn't count that. I want you thinking about something and focused on your exercise for that 150 minutes. That's only 2.5 hours a week, but you should be cognitively engaged and physically engaged, breathing, and yoga and Tai Chi can do that for you. A lot of people, I have people taking our yoga class on Sunday and they're sweating when they get done. It's hard, but 2.5 hours, 150 minutes a week. But talk to a physical therapist or someone like that, someone that has training to know how to best use that time. Now, there's also research to show that much longer periods are good too, but at a bare minimum. Lori Meashley, who is talking at the APDA, she's going to be the headliner. Her research is showing 5, 6, 7 days a week of 20 to 30 minutes a day. That's
okay. Going back into like the different
How do you focus on different areas? That's why we want overall intensity is number one. If you can work out hard for 30 minutes, 20 to 30 minutes, 5 to 6 days a week, or at least 150 minutes a week, that's your number one goal. I mean, that's where all the biking research started, and that's what shows, I mean, it's got to be consistent and it's got to be intensive. These cognitive components are important and should be a part of your exercise routine daily if you're having trouble with cognition. You should talk to somebody about how to tailor your program to fit. And it could be as easy as joining a Tai Chi class, joining a yoga class, joining a dance class that challenges these sequencing aspects or rock steady. But learning where you fall and how to make best use of your time. Because you're going to hear people tell you, you need to work on stretching, you need to work on cognition, you work on intensity, you got to get your blood pumping, you got to be working on yoga and mindfulness, and you got to slow down. And it's like, I give up. I can't do it. 150 minutes a week or more has been shown to slow the progression of the disease in more than 4,000 people with the diagnosis. This was subjective reporting over 2 years. People that were reporting 150 minutes a week or more over 3 to 4 times a week. So not just 2.5 hours one day and then 6 days I do nothing. Staggered out throughout the week, they were reporting higher quality of life than those that were not. So that threshold is what I want everybody to get. Anything else?
How do you make it safe at home? If you're exercising, you need to have a cushion area.
If you're exercising at home, so what we try to do on our videos, I mean, this is very customized to everyone. We can't say that everyone's safe all the time. You know, you have to know your limits, but we try to use modifications, chairs. That's why we do our Chair Fit program, because we want people to still get these cognitive challenges, big movements, challenge themselves, and still stay safe. But like you said, setting yourself up best. If you're going to be working out at home, having, working out with maybe a couch behind you or something, or a bed behind you, so that you know you have a safe place to come back to and sit breaks and those types of things at home.
I'm still looking for a clinician for big folks.
For the big, yes, I saw you. Yeah, we'll talk later. Okay. Anyone else? Thank you all. 12:35, not so bad. Have a wonderful day. And if you need any more information from me, my cards are in the back, and all the information, write down your name and email. We'll get a hold of you.
Thank